Hello again. The next segment is a little different. As the title suggests, in conversation, setting up a hypnotherapy pain clinic in a hospital setting is not the usual straightforward presentation. 4 people will be taking part, 1 person asking the questions and an esteemed panel answering them, rather like a television or radio interview. We have Peter Mabbott, who will be posing the questions, and the panel will be made up of Dr. Alpana Bose, Dato Professor Dr. Tunku Sara, and Professor Marzida Mansour. To introduce them, Peter Mabbott is the President of the British Society of Clinical Hypnosis and a Fellow of the National Council of Psychotherapists. He is also the Head of Academics for the LCCH in the UK and LCCH Asia. He's been practicing and teaching hypnotherapy since the mid-90s, having moved from a career as a researcher in psychopharmacology at Guy's Hospital, London. Dr. Alpana Bose is a psychiatric doctor with a strong passion for clinical hypnotherapy and is an advocate for hypnotherapy within the NHS. She completed a medical degree in clinical hypnosis with the LCCH in 2014. Soon after obtaining her diploma, she established a voluntary clinic for the management of chronic pain in collaboration with the pain team at Great Western Hospital. She is the medical officer for the BSCH committee and medical director of the LSCCH. Dato Professor Dr. Tunku Sara is a Malaysian hand and microsurgeon, retired but continues teaching, researching, and in administration. The first woman orthopedic surgeon and president of the Malaysian Orthopedic Association and past president of the Malaysian Society for Surgery of the Hand. She chaired the orthopedic department at the University of Malaya for 14 years. Professor Marzida Mansour is a consultant anesthesiologist in the Department of Anesthesiology, Faculty of Medicine, University of Malaya. Apart from many medical qualifications, she's done the specialist medical module in hypnoanesthesia and hypnosedation with the LCCH Asia. Her main specialisms are acute, chronic, and cancer pain management, cardiothoracic anesthesia, critical care, clinical pharmacology, and clinical hypnosis. Over now to the conversation, setting up a hypnotherapy pain clinic in a hospital setting.
Hello, everyone. Hello, hello, hello. Wonderful to see you and welcome. First things first, before we get into everything, I just want to say that in 1999, something called REAIM was conceptualized, which means reach, effectiveness, adoption, implementation, maintenance. And it's one of the most widely applied frameworks to plan and to evaluate the implementation of public health and health behavior change interventions. And the REAIM framework report published in 2014 stated that clinical hypnotherapy has a potential of becoming a widely disseminable intervention with significant public health impact across multiple outcomes for a wide variety of patients in medical settings. It also recommends that models of dissemination and integration into mainstream practices are necessary for this to happen. And so with this in mind, my 3 guests, I've been invited to come in to share their experience of bringing hypnotherapy into the so-called conventional medical healthcare arena with the work that they've done in the field of pain management. So it's lovely to see you all. It's lovely to actually have the 3 of you together, albeit virtually. One day, hopefully, we will be doing this in person. Lovely. So I guess the first thing I need to ask, or I will ask, is what challenges did you have when you were trying to set up your various pain practices within the hospital arena? What were the challenges you had convincing your respective institutions to allow this to happen? And Prof. Masida, I'll ask you first.
Thank you very much, Peter, and thank you very much for participate in this session. Yeah, some of the biggest challenges that I'm facing in trying to set up a clinical hypnosis service in tertiary hospital where I'm working is that the recognition that hypnosis can be used to treat pain and can address pain. Many people actually do not know about that. And although it has been shown that this is suitable to be integrated in other treatment in a hospital setting, but we have to make this, we have to create an awareness among even medical professions. And so recognition is a problem, and with that comes problem with reimbursement as well, especially if you want to practice, if the private practitioners wanted to practice this. However, in Malaysia, there have been a review on this, on the use of hypnosis in pain management by the Malaysian Health Technology Assessment Section, and they have come up with an executive statement saying that hypnosis actually can be used in acute procedural pain, especially in areas where the procedure is rather short. It's also useful in women in labor, and they found that hypnosis, parturian that receive hypnosis are less likely to use pharmacological method or analgesia. And in chronic pain as well, it is found to be moderately effective, especially in the elderly patient who can't take a lot of drugs, and as well in patients who are allergic to all kinds of drugs, because I also have patients who are not only allergic to NSAIDs and coxibes, but also allergic to even local anesthetic. That was rare, but yeah, this patient has it. And in the end, we have to think about doing hypnosis for her. And apart from that, a lot of our pain patient also has anxiety, depression, and addiction. And hypnosis is useful in these instances. But in terms of safety, we also, the review also said that hypnosis is safe as an adjunct treatment. And in terms of cost, there are cases where, procedures that have been shown that hypnosis can be cost effective, especially in some radiological procedure or in a minor breast surgery. In terms of organizational, so in Malaysia, we have a hypnotherapy code of ethics that has been developed by the local independent hypnotherapists association. And I think this guideline is very important in order to provide safe, quality, and standardized practice of hypnotherapy. And in fact, for anesthetists, as well as pain specialists who are using hypnosis to treat chronic pain in Malaysia, we are trying to form a board to write a proposal to MMC to recognize this service, so that this service will be recognized as a treatment for pain management, and also in future, practitioner can actually charge for this service. Currently, we are giving it free. And I know this is going to be still at the early stage, and there's a lot of things that need to be done on this. Other challenges include trained staff. We have very few trained staff, like in UM, we started it with LCCH, and I myself had to go for training in order to provide this service. And now what I'm doing is to invite other doctors from other hospitals who also has done has been trained in this area to come and provide their service. Thirdly is time, because we see many patients and we can do maximum of 30 minutes for our patient, and if to include hypnotherapy sometimes can be quite time consuming. And last but not least is referral. Most of my referrals come from my own pain specialists who are from different discipline that refer the patient to me. But we are yet to advertise our services to the public or to the hospital. But interestingly, recently I have been referred a unique case by an oncologist who got to know about my service through word of mouth. And although it is not actually for pain medication, pain treatment. Yeah, those are some.
And do you find that when people are aware of what you're doing, they tend to try and refer clients or patients to you, irrespective of whether they're pain or anything like that? I know, Tunkasara, we had an issue with the pain unit that you were working with the research project, where people trying to sneak client or patients into us. What do you feel about it? What's your opinion on that, Tunkasara?
Well, you mean people, yes. Well, what happened was that word got around that hypnosis is happening in our hospitals in a few different places. First of all, the difficulties were that we were not able to start as a mainstream clinic. So we had to do it as a research clinic, because research, we're a university hospital. So research is, we do research in all sorts of things. So it doesn't matter whether you're mainstream or not, as long as it's safe. So we were able to do that. And we did some hypno surgery, and word got around that this was useful. And of course, oncologists started to refer or try to get us to see some patients who were very anxious and terminal. And there were various people for whom really it was very disturbing that they were not able to be treated in other ways. And so clinicians, tried to sneak in somehow. And of course, if we could, we would oblige, because we also want the best for the patients, because this is a modality which has very few complications, or none at all if done correctly. And yes, why not? For the benefit of the patient.
What challenges did you find trying to set up? I mean, obviously you couldn't go straight in and set up a pain unit or a hypnotherapy pain clinic. You had to go in under the guise of a research unit or research project. Were there any other issues that you encountered setting this up?
You're talking to me? Yes.
Yeah.
Sometimes the board of the hospital is a bit sticky. So as I said, we had to go in to do a research clinic. And then we had to make sure that the indications were really watertight, and also the contraindications, and certain people that we didn't really, who didn't really fit into the indications were rejected. And this was a bit difficult. But we already had a pain clinic run by Prof. Mazida and her team. So we set up a clinic on certain days of the week. So the usual difficulties, such as having a suitable place where there's no sound, and we had to make one of the rooms, as soundproof as we could. And as far away from the traffic of people, and where nobody would barge in, which is actually, I was surprised that it's not that easy to find. We needed somewhere which was conducive, was relaxing, and the chair was suitable, etc., etc. But I think our main thing was administrative, really. That was not a big problem. You know, you can always move the furniture around, put something under the door, but the administrative difficulties, going through the board a number of times, and them asking, you know, is this allowed? Is this part of? And as Prof. Mazida said, you know, where does the remuneration come in, and how do we've never charged for this before, etc., etc. So those were the main difficulties. Other things, of course, we had to get clinicians, because we were doing research. We had to get various clinicians to come at specific times so that the patients could be slotted in on a specific time, a specific day in a public hospital. And we had to get a few people, but luckily LCCH, we had 3 very sort of dedicated hypnotherapy colleagues who came in week after week and helped us with this research, which ended up with good results for hypno surgery, you know, just in carpal tunnel syndrome, which was you know, well recorded, and a student did his master's thesis on it as well. So we're very happy about that.
And Alpana, thank you. That just brings me memories of you running around your hospital with wheeling a chair, looking for different rooms somewhere quiet to set up in. Do you want to explain a little bit more about your challenges?
Yeah, in fact, I'm sorry, I was laughing because it just resonated so strongly with me that I was thinking, gosh, these are global challenges that we face anywhere, in any hospital, in any part of the world, because that's exactly, I think, the biggest logistical challenges were trying to just get a step in. And I think the way I dealt with this is I didn't even think about challenges. I just thought, oh, this is so fascinating. I'm learning this amazing thing and it can help so many people. And oh, I want to share it with my colleagues. So I just went along to my pain team lead. And, you know, I'd worked in that hospital, so I knew her. And I said, hey, you know, Lucy, let's do this. Sounds fascinating and so interesting. And why don't we, you know, try to think of how we can incorporate this in our work as maybe, you know, maybe these are patients that are difficult or tricky, and that hit it, because there are all of these patients that sometimes, you know, all clinicians feel that, oh gosh, we can't do anything more, and you feel so bad because you just can't offer anything more for these patients. So she said, okay, I've got a cohort of patients that, you know, we really can't do anything for, but if you think this is so great, well, go ahead and, you know, we'll see what we can do. But, you know, the bureaucracy has to be followed, and all of these things have to be, you know, we've got to tick all these boxes. So I put together a proposal, you know, collated all this research, put together a proposal, and we presented it to the pain team. And Peter and Charles from the college very kindly came and supported that. So it was really, I think we kind of swept them away in this enthusiasm that we had, and they went with it. And I was really so surprised at the support that we got. And maybe it was because I was being a little bit covert and I was trying to sneak in, and I wasn't going up against, you know, the management of the hospital and the bureaucracy. I was kind of really, I guess, taking advantage of people that I knew, and, you know, the system that I worked with, and thinking of, you know, where is the need here? Where can actually this be shown to be effective and help, so it can be a win-win for everybody? But yeah, I had to do it for free, you know, so that's a huge challenge. You know, over here we've got, haven't got the private system, but it was about funding. So it was very much, you know, we're going to do this as a pilot study, again, under the guise of research. So we're going to do it as a pilot study, and we're going to have to, you know, I was going to have to volunteer my time, and that was fine because I was learning about it and I was passionate about it, and I just wanted to just get on with it. So, and then it was, right now we've got this huge hospital, but it's really busy and busy clinic. So where can we find a space? So I remember we walked around the entire hospital going, no, 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 no. And then finally there was this really small room, like tucked away in the corner, where the gastroenterologists were. And there was this one, very small window of opportunity, like this time, this morning, and that's it, you got to grab it. So I did. And I got in there, and it's, NHS clinic setting, table, chair, and that, examining couch. But there's no comfy chair. And I'm like, I can't make people sit here for 50 minutes or an hour or relax, or even feel relaxed in these chairs. So I had to go around to endoscopy and literally wheel their comfy chair into the clinic room every time, and then wheel it back afterwards. And these people used to look at me like, what are you doing wheeling this chair? I'm like, no, I need it for patients. I need it for patients. And like you were saying, word got around, and then very soon I had people going, oh, we've got IBS patients, or people with like migraine or pain, or other disorders like functional neurological disorders. Why can we send them to you? And I was like, no, at the moment I'm just working with pain, but let's see if maybe we can build the collaboration. And that's what we started doing then, is going around speaking to different departments, and trying to figure out how to integrate it. But we always got stuck with the funding and providing the evidence. So gaining the evidence. So I tried to collate, some evidence in terms of questionnaires, getting people to fill them out pre and post, but getting people to do that was a challenge. People are really great to get the therapy, but they don't particularly want to do any paperwork or anything that goes with it. So collating that evidence was tricky. And then I suppose my own interest then pulled me away, because I then got fascinated by all the people who didn't get better. There were people who got better, and that was amazing. And people walked away from the clinic with no pain, and they'd had pain for years and had multiple investigations. And I think we kind of really exceeded our expectations, and the pain team were just, thrilled by that. But I got really interested in, why is it that people don't get better? So then I had to divert sort of my time into learning about that. So I got into psychiatry, and then I handed over, the pain team to my colleagues. But again, it was trained staff, who would run the clinic if it wasn't for me? So eventually, these are the kind of challenges that you kind of face up against, and there's only so much that you can do yourself, given, all the other constraints that you have as well. So yeah, I mean, I hope to come back to it. It's sort of on hold at the moment, but I really, really would love to come back to it. But I think we can surmount these challenges because, the evidence is there. It speaks for itself. These are patients who do much better. They walk away symptom-free after years of having symptoms. And that does speak for itself. And I think if we can kind of somehow translate that into figures and present that, and keep presenting it, that eventually, we will, because definitely from the clinicians, they were excited about it. They were very welcoming. They were very open-minded. And maybe it's because we were able to speak to them in a language they understood. So we were able to address their issues and concerns in a way that they could understand that, and bring, these worlds together. And bridge the gaps between the worlds. So yeah, I'm very optimistic.
Lovely.
Despite the challenges.
Well, one other challenge that I think anybody who wants to try and do anything in any official setting are the we need them, but they are daunting, the ethics committees. Did any of you, how are your experiences with the ethics committees, Prof. Mazida? I mean, you're doing a lot of work, so how do ethics committees respond to you? Oh, you appear to be...
You're muted.
Yeah, so far I have yet to do any study on hypnosis, so I actually have no experience of how they will react towards it. But in our university, they are quite open to new modalities. I don't think that will be a big problem. Maybe Prof. Tunku Sarah will know better.
Well, for us, definitely ethics committees for research, etc. We had to go through that because we put it under the guise of a research clinic. And somebody asked, did you need to give a higher level of evidence? So we got all the evidence that we could from the literature, but in the end, we just went with the fact that there was very few complications, and so nothing bad would happen to the patients. If anything, what could go wrong? What was the worst that could happen? So the worst that could happen was probably it didn't work. We had the trust of the ethics committee until we actually got our evidence, and then we were able to give what evidence we could, which was, well, we didn't get a huge number. We did actually, I think, about 12 hypnosurgical procedures, but it was we were able to get some evidence to present later on. So I think they were not too sticky about that at all.
So what about you, Alpana? How did you find the joy of ethics?
Yeah, I didn't really go down that route. We did it as a pilot in the guise of quality improvement. So within the NHS, we have lots of quality improvement projects. So we brought it in under that. And for that, you don't need ethics approval because it wasn't research as such. It was more about improving, the service and the quality of service that, we provide for patients. So we brought it under that. Eventually, maybe if we'd wanted funding, because it was all voluntary at the moment, and I worked in the hospital, so we were able to do it that way. But I think if we wanted funding, and we probably had to show evidence, and then would have to most likely go down the ethics committee route. But then, there's other sources of funding, charitable organizations, very supportive. And there's also charitable funds within the hospital as well that were available. So I think there are alternative routes that you can explore, that you don't have to go head to head up with the ethics committee. And that can take a long time as well. The whole process can take so long once you go down the ethics route.
What about funding? I mean, you just been mentioning the funding that's a potential route for you. In Southeast Asia and Malaysia, what are the options for funding?
Well, for like hypnotherapy, right? It's like a service. So we were thinking maybe because it's still a growing thing in Malaysia, and there are not many doctors who actually practice this. So I think the reimbursement from the whatever fee schedules that we have in Malaysia they will take some time to actually include hypnotherapy in the fee schedule. So that's why what we are trying to do is to do something like what the aesthetic people have done. Yeah, like aesthetic is under the purview of MMC, and they can charge, and they don't come under subspecialty, but it's just a kind of service that's provided and recognized by MMC. So we were thinking of having hypnosis under this category as well.
And Prof. Mazidi, you've been, or you're supporting the inclusion of hypnosis in the Pain Society, the Malaysian Society of Anesthesiology. How have your peers responded to that?
What is this hocus pocus thing? But with more and more evidence that's available, so people are looking at it. And after all, chronic pain, especially, there's some of the pain cannot be treated as well, and because of that, I mean, modern medicine cannot treat the pain, so people are using other methods as well, and hypnosis is one of them. And yeah, so but now I think people are more open to it, and thank you to LCCH have done a lot of thing to create this awareness, and we have seen that it does work. It does work because most of our pain patient, after the quick fix, they want the interventional work, injection here and there, and after taking all the drugs and doing all the physiotherapy, they're still having pain. So what's next? Yeah, we're using a lot of behavioral therapy, and I find hypnotherapy is sort of enhance the quality of CBT that we are providing to these patients, and they love it. And even my students love it, looking at, observing me doing this therapy for the patient.
Dr. Sarah, how did your patients react when you were saying, for carpal tunnel surgery patients, here is hypnotherapy, here's an option for you? What was the sort of feedback you got from patients when that was given to them?
Well, it was a mixed, it depended on their beliefs. But we were able to convince most of them, even those who had a phobia for surgery, actually were able to go for surgery and have their carpal tunnels released. So there was mixed, and some people were interested to see what it was all about. And we told them that they would go for introduction sessions, with the hypnotherapist, and that they could back out at any time. So they were quite comforted by that. But somebody has asked, I think asked Dr. Alpana in the chat, what are the patients that, for me, because I'm a hand surgeon, I see a lot of brachial plexus injuries. So paralysis that occurs when you come off your motorbike and your plexus is torn or ripped out, and these patients get incredible amounts of pain. So in the case of these patients, it was really desperation, really. It was desperation. And we found that hypnosis works quite well on neurological pain. We actually, my research assistant, Izati, did her master's on that. And the pain scores really came down quite significantly. We were comparing what is it called, acupressure with hypnotherapy, and somehow this neurological brachial plexus, or what we call brachial neuralgia, which is, some people almost go suicidal because it's really severely painful. And they were very pleased with the results. So as I said, they were desperate. So they didn't care what we offered them. They were willing to go along with it.
Now, Dr. Alpana, Napur, referring to what Tom Kasara was saying, Napur is asking in the chat what insights you came across for patients who were unresponsive in pain management to hypnosis. Any insights on what they might be experiencing?
That's a great question. From the experience that I had, pretty much everybody who committed to therapy went with it and could put aside their maybe assumptions about hypnosis, what they'd seen on television or what they thought I was doing, and could go with it and really embrace it as if it was, something that they were really doing for themselves. The more they could do that, the better the results. And it was just fascinating to see. It was those patients who, for some reason, were not really ready for that. Like there was either some secondary gain that was unconscious, or there was some kind of interpersonal problem, or there was some other issue that was sort of coming in the way of the therapeutic alliance and their actual wanting to take that step to commit to therapy. I think that's where the issue was. Once you've got them hooked and they're in that relaxed and they're doing it, I think, and they see the results, then they're like, yes, this is great. But it's getting them to that point. And what I found really helpful was producing a leaflet. I know, Peter, you and I spent so many hours in getting the wording just right for the leaflet.
Oh, I remember.
Draft version 10, version 11. So the leaflet was very good. So we produced this leaflet, and it was given to patients when they were referred. So, you know, when Dr. Williams would be talking to them about potentially referring them to me, then she would give them my leaflet and say, you know, have a think about it. Any questions, let me know. And then I would call them and say, you know, hello, you know, my name is Alpana and I work here and this is what we do. Do you have any questions? And then we book a time. And then the first session would be just sort of dispelling myths and just really trying to understand, what is your understanding of hypnosis? What are your expectations from this? What are you willing to do? You know, because it's not me waving a magic wand. It's not like you said, hocus pocus. It's not that. This is something that you're going to learn and you're going to do for yourself. And it's going to be lifelong. It's going to be like a tool that then you can use for everything and anything that you want to. So it's just much more than what we do in clinic. And I think when people got that and when they started to go with it, that's when it really worked. So yeah, I started and I wanted to explore, you know, what is this in this therapeutic alliance? What is happening in this interpersonal relationship? So that's why I kind of thought I need to learn more about workings of mind. So I ended up in psychiatry. So actually hypnotherapy is what inspired me to go into psychiatry, and I'm doing psychotherapy, trying to understand that even deeper, and hopefully I can full circle back to hypnotherapy and really be in that room going, okay, now, you know, what is it here that's happening between us that we can work through so you can get benefit from this treatment. I hope that answers that question.
Yes, thank you. Prof. Masida, we're talking about people who respond well. What about the ones who don't respond? Have you any experience? I mean, how do you work with, or how do you handle somebody who is going in for a procedure or whatever and is not responding to the hypnosis?
Well, in the pain clinic, I do have some patients who are not responding like this. Oh, I still have the pain, but I noticed, like, even if they say that they are not happy and the hypnosis is not helping with the pain, but when I examine that, it actually has benefited them in other sense, like they are less anxious and their personal life is much more in control. So they do get other benefits, even though the pain is still there. And yeah, then I will use different tricks, like, oh, life still has to go on even when you are in pain, that kind of thing.
Dr. Sarah, with the brachial, carpal tunnel patients, how many out of the cohort that you were working with, how many actually went through the full procedure and how many needed to have some form of anesthesia?
Oh, I'm let me see. I think there were about, I can't be absolutely exact. I think there were about 12 or 13, and none of them actually completely refused to carry on, but we had to top up with local anesthesia in that one patient who was having a phobia for surgery, and she wouldn't have come at all to the surgical theatre if we hadn't offered her, and she hadn't gone through hypnosis. So we had to give her a little bit of local, and it was successfully done. So I can't recall. I think there was one other patient that we had to give local anesthesia to. So out of probably about 12 or 13, only 2 were topped up with local anesthesia.
How did you select people for that? I mean, were they pre-selected? Were you doing, any of you, were you doing any of the suggestibility tests or hypnotizability tests that are out there?
No, I don't think we did a hypnotizability test. The only thing we did was probably to see how open they were to the procedure itself, and because we were trying to recruit as many as we could. So no, we didn't do the hypnotizability, but I guess the first hypnosis session itself was a test of that. Yes, but yeah, I think if there's a huge number and you need to restrict, yeah, that would be a very good idea.
And I've got a message here from Drake who says, is there any way we can get a copy of the leaflet? Alpana, do you still have it?
Yeah, I do. Yeah, sure. No.
Are you happy to share
Yeah,
it with?
absolutely. Yeah, very happy to
the
share.
delegates?
Yeah, and I was very happy to share the draft proposal and, you know, the proposal that we submitted or whatever. And it's very out of date now, probably needs updating, but yeah, very happy to share any documents.
Sweated blood over that. So what was the attitude of people around you, your colleagues, with regards to it? Alpana, you had some quite positive experiences. Were any of them sort of, oh no, I mean, as Prof. Mazita says, some of them think it's hocus pocus. Yeah, I still remember one of my own little sharings going and was talking at the Nursing Times conference and having a couple of people walking up to me afterwards and asking me literally, are you born with the power to hypnotize, or do they teach you how to find it within you? And I thought they were taking the mickey out of me and having a joke with me, and then I realized they thought, my eyes spun and little dots come out, and ooh. So there's still quite a bit of work to do there, but what about your experiences, Alpana?
Well, overall, very positive. I was laughing at that because it really was, I had similar, like, you know, can you learn how to do this? Can I learn how to do this? Or do you just naturally have this? I was like, no, I went and got training, and I think it helped with that, because having the medical diploma from the college was very helpful. And again, you know, colleagues could see that, you know, you're properly trained professional. Because I think the other worry for especially, you know, I guess everyone, but in the healthcare setting, is the training. You know, what is your standard of training? There is no law in the UK that, you know, hypnotherapists need a specific amount of training. So anyone could just tomorrow be a hypnotherapist. So it's really important for patient safety, and, you know, so that clinicians know that their patients will be treated in a safe and effective manner, that they have that reassurance. So actually having my medical diploma and showing it to them, I think that reassured. And they were just very excited about any new idea, and they were extremely excited about me possibly being able to help with patients that they had run out of options for, because those are the sort of patients that come again and again. You try every treatment, and that it is quite disheartening as a clinician, I think, when you have to tell someone, look, there's nothing more we can do for you. So they were able to then say, well, actually, you know, why don't you go see Alpana? He could try something that I could be the one to say, oh, sorry, there's nothing more you could do. But no, that wasn't that. Like I said, everyone who committed did really, really well. And I think we exceeded the expectations. And so then when I started talking about this, so we had the gastroenterologists used to do their clinic next door. Then we had the neurologists who used to work very closely with us as well. So they heard about it. And then I went to speak to them. And we were about to start another project looking at anxiety in Parkinson's, which is also very, very difficult to manage. But again, like I said, I got pulled into psychiatry. Within psychiatry, though, I have to say, that is where perhaps a bit more resistance, a bit more like, what are you doing here? I'm not quite sure. And I remember presenting to my department and one of the psychiatrists saying, well, you know, the hypnotherapy may not have side effects, but maybe the hypnotherapist does. And I thought that was a very interesting comment. And perhaps that reflected on this idea that, you know, about training and standards and the fact that, you know, medics have to go through so many exams and you have to always show your competence. And maybe there was some anxiety that he was holding around there. But actually, on the whole, after the presentation, you know, even he was very much up for trying it. And I ended up running a hypnotherapy for well-being and healthy eating for staff at my department, which, yeah, they really, really enjoyed. So I think it's about addressing, actually being really open and honest about things and being transparent and addressing these issues and really meeting the concerns with an openness and an honesty.
One thing you mentioned there, which got me thinking back to my old profession as a psychopharmacologist, or pharmacology by nature. Prof. Mazida, how do you find your colleagues respond to the idea that we can do things just using the mind without having to give a drug? I mean, my background was researching the benzodiazepines, so the concept of hypnotics has been around for a long time in my head, but I was in sedative hypnotics. You sort of pop a pill or inject it and go into a trance-like state. How are your colleagues finding that idea, the move away from pharmacology potentially into the use of the mind?
Yep, I can see the benefit of it a lot in the pain clinic. But as a hypno sedation or as a hypno anesthesia, of course, all my colleagues will ask me, haven't you heard of propofol or midazolam and all those? And why do you need to do hypnotherapy? But there'll be some instances where hypnotherapy, you have no choice but to do things that is non-pharmacological. Like I have this patient who, you know, I think the video has been shown, I think, by SCCH, how this patient just so scared to receive the local anesthetic injection. Just that part. I mean, most people could stand it, but for her, it's a terrible trauma, and she wants to be hypnotized to receive that local anesthetic injection. And following that, the surgery can be done. And that, so in these instances, for instance, I had to hypnotize her. And when, and not just my colleague is surprised with the results, even I myself was surprised because she was very calm. In fact, even the blood pressure dropped quite a bit, and my anesthetic nurse asked me, shall we increase the blood pressure by giving medication? And I was like, oh.
And it was one of the areas I was first brought into when I first trained as a hypnotherapist. In those days I was working with guys in St. Thomas's, and I was doing pharmacological research as part of my team with the hypertension unit. And when I moved away from all that and became a hypnotherapist, they brought me in to work using hypnosis with hypertension. And just the act of going into trance, blood pressure goes down. And we had patients who were having to be taken off their medication because they were going hypotensive through the lifestyle change work we were doing and the practice with hypnosis. It was fascinating. Fascinating. Tukasara, what about yourself? I mean,
well, regarding resistance, the first thing everyone says is, will I give out my PIN number to the bank? And they're like half joking, and of course you have to dispel this myth and say, no, you know, you can't give out anything without your actual knowing about it, because you're not unconscious, you're actually just under trance. So yeah, because we do send people for training, and that gives rise to a little bit of resistance because we have a deal with LCCH that they use our premises, and we send some of our staff. And yeah, I've tried to send those people who who are kind of resistant to change and that kind of thing, and not so adaptable. And most people enjoyed it, actually. There was a doctor who said that he hadn't been overseas to a conference because he was anxious about living away from home. There was some anxiety that he had sleeping, away from home, and following doing the course and actually doing self-hypnosis, he was actually able to go freely, and he went and did his hip course and his knee course and all sorts of other things in various countries, in Korea, and I think he went to UK as well. So yeah, I think if you have a number of people who are able to convince the colleagues, around, you can just say, oh, look at so-and-so, or go and speak to so-and-so. And that's very helpful to have just the correct number of people that you can go and speak to.
So, I mean, sorry, Prof. Mazita.
About self-hypnosis, I actually did it for myself, and I went to the to do my teeth, where I feel like it's not the pain, it's I feel like I want to cough out, and I just couldn't stay still for a long time. But with the hypnosis, I was able to withstand the procedure and didn't have to. I also am a lot of my colleagues with self-hypnosis, and that make them interested, because it's not just for patient, it's for yourself as well.
Yeah, definitely.
And I think
Yeah,
you've
absolutely agree.
certainly seen with what's been happening in the world with regard to the pandemic, frontline responders very much need that TLC and teaching self-hypnosis, and having a means by which the people at the front line, the people doing the helping, can also receive help is very, very important. Do you feel that this is something, I mean, Dr. Alpana, you've had experience of this as well. Do you feel that this is something that really should be spread out now within hospital environments globally?
Absolutely, absolutely. I think there's something very powerful about the experience, and once you've experienced it yourself, because it's such an experiential thing, I think you can go around talking about it, but actually it's like, well, come and experience this. And once you've experienced this, then you know for yourself. So I was a cynic coming into it, and I cured my insomnia for 7 years with self-hypnosis. So, I think once you really know it to be true, then you can speak from that. And then, you want to share that with your colleagues as well, because why should you unnecessarily have to suffer when there's a better way? So with the well-being and healthy eating, once they'd learned those techniques, and it was great because we had lunchtime sessions, and that was some time for them to just focus on themselves and have that really relaxed state. Something very nourishing about being in that very deeply relaxed state, especially when you're working in a really, really stressful job. So just be able to pause and to integrate that into the working day. They just seemed more motivated. They were just had more energy, and they were so excited, like, oh, I've lost this much weight, and there was just such a buzz around it that and I think that does filter into your work, and then ultimately it will filter into your patient interactions and patient care. So it's not just for us, actually. Ultimately, whatever we do will filter into patient care. So we're not just doing it really just for us, we're doing it also for our colleagues and for our patients. And yeah, definitely. I would really like to see it being introduced more in the well-being program. So at the moment, with the pandemic, I think that's one thing that's come out of it, is this focus on well-being, which has been really great. Really want to capitalize in on that and introduce a program for healthcare professionals, for well-being, because at the moment we've got mindfulness programs and other programs running, yoga, Pilates. So, why not hypnosis? We need to get hypnotherapy in there, definitely.
I mean,
I actually used it on my students as well, because before a session, they're all like rushing here and there. So I said, okay, give me 5 minutes, and did a bit of group hypnosis, rejuvenate and re-energize, etc. And yeah, I think they were quite what can I say? They were quite happy about it. And as you say, there's a buzz there about this is something new, and it's not sort of evil, sort of hocus pocus, as you say, and it's for everyone. Anyone can do it. So yeah, it's very interesting. It was very interesting.
I started the conference off yesterday morning talking about compassion. Do you feel, as clinicians yourselves, that this practice of hypnosis on yourself, self-hypnosis, increases your ability to be compassionate? Who would like to say something about that?
Well, it's a fantastic question, and I think the main thing for me is that it sort of shifts you out of that fight, flight, freeze that you're continuously bombarded, and you'll feel like you're firefighting all the time. And somehow what that does is that kind of pauses that, and you're like, okay, and you can go into sort of more of a thrive, right? How am I going to navigate this in a way that actually I can learn from it, other people can learn from it, and I can then move forward, not thinking just from a very shut down fight flight way, but actually I can increase my sort of brain cognitive connections, whatever way you want to put it, and really be present in this moment. Because, as we know, when we go into massive emotional dysregulation, then your prefrontal cortex will shut down. It will shut down. That's just neurophysiologically going to happen. So it's sort of trying to really put a brake on that. It's putting the brake on, just like slow down, put the brakes on. We're gonna totally burn out if you're going in fifth gear the whole time. So we've got to do it for ourselves. And then when you can do it for yourself, then you can share it with others. You can't give something to someone else that you haven't got, I think.
Yeah, I think to do with compassion, for me, it's the ability to actually act rationally on it, because, I think it's too much. I tend to have too much. Sorry, there may not be such a thing, but I really feel sorry for all these people sometimes. And when you hear, oh no, not another relative with cancer, and not another, and sometimes you need to just relax and sort of be able to tell yourself what you can do about it. What can you do about it? If you cannot do anything, too much of this sorrow and stuff is actually not good for you, because you feel stressed out that it's happening and you can't do anything. So I would say the actual good part is where you can do something about that with the compassion, with your new skill.
Yeah, and I think just adding to that, being able to stay with the suffering, compassion is staying with someone's suffering, to be able to stay with that without being overwhelmed, and be able to then help someone navigate that, through it as well. I think that's been really helpful. Not only, and it's just not just in the clinic room, but I think it's one of those lifelong skills. And even in psychotherapy now, I find that really helpful to be able to do that, to go into that kind of state where I can just be with someone and hold and contain that with them.
Lovely. Thank you all for your responses. But I know we could talk for hours on this, and I wish we had hours to talk. And I wish we could bring everybody in who's been picking questions out as they've been popping into the chat. But thank you all very, very much for sharing your experience, for joining me in this conversation. And I'm going to hand over back to Tom before he throws something at me and tells me I've run out of time. So thank you very much, everyone.
Thank you very much. It's really great to be here.